Thank you very much. Gosh, the energy here is remarkable. It's really good. And thank you for that introduction. And I just want to say that, it is women with ovarian cancer, their friends and their families that motivate people like me to continue trying to push the boundaries, further research, increase collaboration globally, and helping the community as a whole. So thank you, Rumsi Overcome, for allowing me to spend some time with you. I just want to see if you can see my slides. Are you able to see my slides?
Yes, we are.
Great, that's a good start. Okay. So, as you said, I'm a medical oncologist, and I work at the Royal Marsden and lead the research program here and see patients day to day on standard of care treatments, which are approved, and also clinical trials. I'm also currently the president of the Royal Society of Medicine Oncology section, and thank you for inviting me. I work with a number of drug companies, advising, teaching, education events, and for full disclosure, I'm also the lead of the RAMP 201 study that I'll mention, and European lead for RAMP 301, and I'm a co-author and investigator on some of the trials that I mention in low-grade serous ovarian cancer. So I'd like to start. I know I don't need to tell this audience, but I think it's really important to remind ourselves that when we talk about ovarian cancer, it's more than one disease, and it's very individualized, and the care and the treatment also needs to be personalized and individualized. Now, I put this slide together more than 10 years ago now, but I think it is still highly relevant, and where you see the differences in the types of cancer within ovarian cancer, and there are particular sort of genetic abnormalities that may be relevant for treatment. And there certainly are different outcomes from treatment for women with different subtypes of ovarian cancer. So the key is that treatment needs to be individualized, and there is much more recognition of this globally, not only from patients, but also from the cancer teams looking after patients. So, and some of these slides that I'm showing you really triggers for me to speak to you about certain aspects. This is one of my patients who highlighted this rare cancer, low-grade serous ovarian cancer. She was only 23 when she was diagnosed. And here are some quotes. I won't read them all out. You can see what this was about, and I'm sure they resonate with many of you about symptoms, lack of early diagnosis, and also the hopes and the fears that I'm sure many of you may share. Unfortunately, Emily passed away in 2023, but her motivation, her hope, her struggles are with us as we continue the quest to improve treatments for low-grade serous ovarian cancer. So I know that many of my slides may appear data heavy, but it's really for me to share with you what the medical community also aware of, and I would explain some of this in more detail when I show you some data from slides. But just to say that low-grade serous ovarian cancer is considered a rare cancer. It's up to 5 to 10% of ovarian cancers. And importantly, it can arise from a benign tumor called serous borderline. And as many of you are aware, looking at the age distribution of women with ovarian cancer, there is no set age. This doesn't just affect older women. In particular with this type of cancer, most common in the 40s and 50s, and as I've just shared with you, patients can be in their early 20s and 30s. And compared to some other forms of ovarian cancer, low-grade serous ovarian cancer is less responsive to our traditional chemotherapy. However, generally compared to, for example, high-grade serous ovarian cancer, generally the survival is longer. But what I'd really like to say, and I know that you know as women in the group, that there is a huge spectrum. Some women can live for many years with this type of disease, whereas others, sadly, the disease may overtake sooner than we would like. So what do we know about low-grade serous ovarian cancer? Well, we've learned a lot from the molecular profile. So unlike some other cancers, we know that there are certain molecular aberrations or abnormalities, for example, KRAS or BRAF or NRAS mutations. We also know that hormone receptor expression, the estrogen receptor, is relevant here, as some of our treatments actually target the anti-estrogen pathway. Also, we all are aware of BRCA mutations and the progress in cancers, in particular, that have BRCA mutations. In this disease, BRCA mutations are rare or not present, and are probably not driving this disease. What I'd really like to highlight, as I mentioned, I'm an oncologist, so I give drugs. Surgery is key. Throughout the management of women with low-grade serous ovarian cancer, I always consult and in the multidisciplinary setting about the role of surgery, not only at diagnosis, but in recurrent disease. I've explained that chemotherapy doesn't work as well as I'd like it to, but there certainly is a role for it. We need to remember that as well, in an area where we need better treatments. Now, more targeted therapies include, as I've said, hormonal therapies. I actually mean anti-estrogens there. Also, what we call anti-angiogenic treatments. So these are drugs that attack blood vessels that feed cancer, for example, bevacizumab or Avastin, and also a class of drugs called MEK inhibitors. So I put this slide in really to remind myself to highlight the importance of a team. You've talked about teams with Overcome, and treating women with ovarian cancer is a team approach, from diagnosis throughout the pathway, and it involves a multitude of specialists and expertise, from oncologists to surgeons, the pathologists, the nurses, the geneticists, radiotherapists. So, you know, there's a huge team here, and also the importance of survivorship, and recognizing that more, the importance of nutrition, psycho-oncology as well, in living with and beyond this diagnosis. So that's really important. And also, in particular, in rare cancers where our treatments need to be better, always consider and highlight the need for clinical trials and referrals to clinical trial centres. So I'm just going to mention a few aspects about drug treatments now in newly diagnosed ovarian cancer. I just want to say that I don't normally sound this nasal. I've got a cold, so if I've got a tissue in front of my face, it's because I'm trying to manage a cold at the same time as speaking to you. So, so in the first line setting, we know in patients that need to start with chemotherapy from a variety of retrospective analyses within trials, we know that the response rate to our first line attack mechanisms, carboplatin and paclitaxel, is around 25% or less. And also in this setting, in some studies, we've seen retrospectively that perhaps with chemotherapy versus no chemotherapy, that we can't really see a huge survival difference. Then we've also looked at the addition of bevacizumab to chemotherapy and continued as maintenance. And in a subset analyses, because these trials weren't just low-grade serous ovarian cancer, but it looks like bevacizumab could be helpful in low-grade serous ovarian cancer with an improvement in time before cancer worsening. And then a retrospective study from the US looked at this maintenance hormonal therapy approach. And it looks like that, that with drugs like letrozole, for example, that the time before cancer worsening is substantially increased compared to chemotherapy alone. And therefore, this is ongoing in a clinical trial led by the US. So what about recurrent disease? This is when cancers come back, usually after surgery and first-line treatment. Well, the so-called platinum sensitive and platinum resistant terms that we use historically, traditionally, I think may not be so relevant in this disease. But if we look at it that way, as you can see, the response rates to chemotherapy alone, far too low. And actually with hormonal therapy, for example, letrozole, the response rates are actually a bit higher, 9% rather than 5 and 2%. Now, in some studies, if you add bevacizumab, that response rate seems to go up. Now, that again is retrospective, so it's not a clinical trial just in low-grade serous ovarian cancer, but still encouraging, and we need to learn from real-world experience as well as clinical trials. And then the real breakthrough, if you like, that's given us hope in this disease, which is MEK inhibitors. For example, drugs called trametinib or binimetinib. It all kicked off with selumetinib, with likelihood of shrinkage, that's response, ranging from 15 to 26%. So just to change tact a bit, how do I treat this disease? Well, I always consider surgery to remove all disease. But even if there's low volume disease left behind, I think it's a good idea to have the opportunity for surgery. That may help with symptoms or preempt certain symptoms that could be problematic in the future, like bowel blockage, bowel obstruction. I always, personally, this is my viewpoint, always consider first-line chemotherapy, and that is carboplatin and paclitaxel. But early stage, for example, stage 1, I think it's fair, given the evidence or lack of evidence, to discuss no chemotherapy. In advanced disease, I consider chemotherapy with potentially the addition of bevacizumab, followed by maintenance bevacizumab. As I've mentioned earlier, BRCA mutations don't tend to drive this, and PARP inhibitors are more relevant for high grade. So I don't really talk about PARP inhibitors here because they won't really work. But I do consider hormonal therapy. I appreciate ongoing studies, but some patients around the world have been considered for and taking hormonal therapy as a maintenance approach. In terms of follow-up, what do we do? Well, we all look at CA125, but it's not as informative as some other subtypes. So in my practice, I also, as well as obviously reviewing the patients, thinking about symptoms, which can drive a lot of suspicion for recurrence, but also CT scans. So in recurrence, as I've mentioned, I always consider surgery to remove all disease. I consider a MEK inhibitor. I do consider chemotherapy. I certainly have seen some patients benefit. It may not be long-term benefit, but it can certainly help in terms of burden of symptoms at a particular time point. Hormonal therapy, and with bowel obstruction, in specific circumstances, I do consider parenteral, which is intravenous feeding, if it's the bowel only that's the problematic area. And clinical trials, as I know you're excited to hear about. So in terms of the US, I'm looking at FDA here. There are no specific FDA-approved options for low-grade serous ovarian cancer. And the all current available treatments generally have a response rate, as I've mentioned, is around 25% or less. But there are promising treatment approaches, and thankfully a lot more research specifically for this disease, low-grade serous ovarian cancer. Now, this is more a diagram to show me and remind me to tell you that the real areas of interest are trying to manipulate that anti-estrogen approach with hormonal therapy like letrozole, for example, or fulvestrant. These are drugs that we commonly use in breast cancer, and to learn from our breast cancer colleagues and patients about other drugs that may have relevance, like targeting other pathways like CDK4/6 inhibitors. But also this pathway that we're very interested, which involves MEK inhibitors, and really trying to attack this molecular pathway at various stages to try and combat and slow down the cancer and any resistance mechanisms. And these mutations are not rare in low-grade serous ovarian cancer. For example, about a third of women may have KRAS mutations in their tumor. So this is not hereditary, just to be clear. This is about abnormalities in the tumor. So here are some phase 1 and phase 2 studies that have happened or reported, and really forgetting the names of the drugs, it's really a range of drugs affecting hormonal pathways. There actually was one study of a small number of patients that involved a PARP inhibitor, a laparib, and a MEK inhibitor, but others are generally combinations of different types of MEK inhibitors. So if we look at one study of hormonal combination, this is a US study of ribociclib and letrozole, that's a CDK4/6 inhibitor. Early interesting results, response rates of so far of what's reported of around 23%, but the duration of response is what's meaningful. It looked relatively long-term, 19 months or so at the time of this study report in 2023. Now I'm going to move on to MEK inhibitors. One of the first randomized phase 3 studies was this study in got-OV11 Milo. And this looked at patients with low-grade serous ovarian cancer being randomized to this MEK inhibitor, binimetinib, or physician's choice of chemotherapy. And that was doxorubicin, paclitaxel, topotecan, drugs that I know you're familiar with across ovarian cancer. And we recruited to this study. I was very enthusiastic about this. And I certainly saw individual patients benefit. But overall, in this study, there was no survival difference compared to chemotherapy. And no difference in progression-free survival. So that's time before cancer worsening. It was 9 months versus 10 months. The response rates were actually 13 versus 16% initially. And then with a more updated analysis, that response rate was around 24%, but similar with chemotherapy. What does that teach us? A few things. One, it's possible to deliver important clinical trials in rare cancers. People thought it's not possible. People won't get together to do it. Patients do travel. Patients really want to be involved in clinical trials to improve standards of care now and in the future. So I think we learned from this and we continue to learn. Also, again, I see that chemotherapy here can play a role because we didn't see a difference compared to this MEK inhibitor, binimetinib. The other important point is side effects of treatment. And I really want to labor that because it's about living well as obviously the symptoms of cancer. In this study, around a third discontinued treatment due to side effects. Okay. What we did also learn was that the time before cancer worsening was longer in women with a KRAS mutation than those that didn't, which is giving us the signals about the importance of KRAS mutations. The next study that I want to highlight was the trametinib study. This was a US and UK collaboration. Again, a randomized study in low-grade serous ovarian cancer, very similar to the other study, but we also included endocrine therapy, letrozole or tamoxifen, as a treatment choice. Now here, the results were slightly different. And what we see with these curves, which you can see sort of separate, is that the time before cancer worsening, that's the PFS, was longer with trametinib compared to standard of care treatment. It was 13 months versus 7 months. And overall survival numerically appears longer as well, 37 months versus 29. I also think it's important that we can see in this study what our control arm response rates are. Letrozole was the highest, it was 13%. Chemotherapy was under 10%. Tamoxifen was 0%. Trametinib was 26%. So in many areas of the world, this is now available as a potential treatment. Now, in this study, retrospectively, we looked at KRAS mutation status, and there were signals that the response rate with trametinib was better in the KRAS positive group. Side effects, again, I've highlighted to you, very important. They're different to chemotherapy, but certainly not trivial. And in this study, discontinuation due to side effect was again around a third or more with trametinib and 30% with standard of care treatment. And there are certain side effects we need to be aware of. They're rare, but they can affect the heart, the eyes, and also the lungs, called pneumonitis. So this brings me on to remembering to mention toxicity management of MEK inhibitors. The most common is about skin rash, which can be like an acneiform skin rash. And this is not, it's a very visible side effect. we're much better at treating that. So we often preempt this and give topical antibiotic creams, steroid creams, and also sometimes we need to give oral antibiotics or steroids. But we really want to, sunblocks, for example, emollients. This can really help. Other side effects, you can get loose stool. We can use loperamide. They can be eye toxicities and heart toxicities. This is more rare, but very meaningful when this happens. And so it's really about that multidisciplinary management with eye experts, heart experts, and along with other targeted treatments, inflammation of the lung, which is called pneumonitis, we're much better at treating and picking this up. And there are standard pathways of how to treat this. Now, in the last few moments, I'm going to highlight hopefully a very exciting development, and I'm going to show you the pathway of this. Now, this is a combination of MEK and FAK inhibitors in low-grade serous ovarian cancer. There was lab work that suggested that this combination could actually be helpful in overcoming resistance to MEK inhibitors. And we showed back in 2021, this was an academic-sponsored phase 1 clinical trial led by the Marsden and ICR team, and small numbers, but we know low-grade serous ovarian cancer is rare. So we treated about 24 patients. We saw a response rate of 46%. It was higher in the KRAS mutated. But importantly, what I could see with patients that I knew well, who'd previously had a MEK inhibitor in trials, that some patients got a further response once their cancer got worse on another MEK inhibitor. So responses in patients previously treated. So that was very important and exciting, and led to a number of headlines back in 2021. And I raised this because, again, it put the light on a rare cancer, ovarian cancer, but low-grade serous ovarian cancer, and this was covered worldwide. And this also then led to this phase 2 study called RAM201, a worldwide collaboration led by myself from the UK, involving Europe and the US, and many patients have contributed to this worldwide. This looks complicated, and it is, but really to show that we really wanted to find out the right dose, the combination, and expand in more women with low-grade serous ovarian cancer, so we could get a better feel about this disease rather than treating 9 or 10 patients. So I'm going to show you some of the headlines. Just for this, I want to tell you that it's for me to remind you that around 20% or so had prior MEK inhibitors, around 50% prior bevacizumab, and this is 115 women with low-grade serous ovarian cancer. And what we showed is that overall the response rate was 31%. It was higher in the KRAS mutated group, 44% versus 17%. And we did see responses from a large number of women, over 100 now, 33% without a prior MEK inhibitor and 25% with a prior MEK inhibitor. What's important is these responses don't necessarily happen immediately. It can take a few months. But the duration of response was in this study so far around 30 months, okay? So this is what we call a waterfall plot. Anything below the line across the page is tumor shrinkage. So even though there may not be 30% shrinkage, which means a formal response, and that's where the dotted line is, you can see that the majority of women had some degree of tumor shrinkage, which can be very helpful clinically and helping in symptom burden. 82% of women had a reduction in their lesions. Side effects, so far, and we need to know more, but around 10% discontinued due to adverse events or side effects, compared to what I've showed you before in other trials of MEK inhibitors where it was more than 30%. So this has led to the ongoing RAM301 study. This is a real worldwide collaboration. If you look at the bottom of the slide, you can see all the groups across the world, from Australia, New Zealand, Europe, the US, South Korea. This is a real collaborative effort of women with low-grade serous ovarian cancer. This is our definitive phase 3 study to really assess whether this combination of oral treatment compared to chemotherapy or hormonal therapy can be better for women with this disease. We do have what we call crossover built in, so for patients that are in the investigator's choice of therapy. If there's confirmed cancer worsening, there's the ability to cross over to the avatimatinib and defactinib. So also want to highlight some press releases. We know that the drug company that makes this drug combination, Verastem Oncology, have initiated a submission to the FDA, which is under review for women with low-grade serous ovarian cancer in the KRAS mutated group initially. So let's watch this space. There are other ongoing trials, again, as I say, combinations with hormonal therapy mainly. And I want to highlight ADCs, I'm sure you'll hear about them later, antibody drug conjugates. There may be a place for this in low-grade serous ovarian cancer. There is a study that reported that folate receptor expression may be relevant in low-grade serous ovarian cancer. So mirvetuximab might be applicable, but we need the clinical trials. We also need to look at biomarkers to predict things and potentially looking at circulating DNA as a biomarker. So I want to alert you to this report, which was published last year, looking at specifically at low-grade serous ovarian cancer. Many experts around the world, including myself and some names I'm sure you recognize in the field, contributed to this. We all met to put this together. And importantly, there was the patient perspective as well. And I just want to highlight from this publication, one of the patient perspectives from a survey of 71 patients, really important questions. What are the most important issues for women with newly diagnosed low-grade serous cancer? And I'm sure many of these that came up resonate: access to best care, side effect management, risk of recurrence, fertility options, treatment options, understanding the disease more. So I think that's a really important piece of work and is ongoing. So what do I think about the future? Well, we clearly need better treatments across the line at diagnosis and recurrent disease. We need to think of maintenance therapy options. And how do we monitor this disease better so that we can select patients and predict how long they may benefit from a certain treatment, taking into consideration quality of life? So I just want to highlight again, I've mentioned patient groups, Overcome. This was a UK patient participation group, and many on World Ovarian Cancer Day contributed to this in London, where I'm based, a couple of years ago. And I just want to end by thanking all groups, international collaborators, and some of my patients that have driven a lot of the patient advocacy for low-grade serous ovarian cancer, and all the teams nationally and internationally. Thank you very much.